And now I'd like to introduce Dr. Micky Tripathi. Dr. Tripathi serves as Assistant Secretary for Technology Policy, National Coordinator for Health IT, and Acting Chief Artificial Intelligence Officer at HSS, where he leads the formulation, technology and data strategy, and coordinates technology policies, standards, programs, and investments. Prior to his roles at HSS, he served as Chief Alliance Officer for Arcadia, was a project manager of the Argonaut Project, an industry collaboration to accelerate the adoption of FHIR, and a board member of HL7, the Sequoia Project, the Commonwealth Health Alliance, and the Caring Alliance. Dr. Tripathi also serves as president, and he also served as president and CEO of the Massachusetts eHealth Collaborative and was the founding president and CEO of the Indiana Health Information Exchange. Dr. Tripathi, welcome to our event. We're very excited to have you here.
Great. Thank you, Carol. Thank you for the kind introduction and for the opportunity to be here. And thank you, everyone, for joining. Really look forward to being able to describe to you all of the work that we've been doing at ASTP. My office, the Assistant Secretary for Technology Policy and the Office of the National Coordinator, which is a mouthful we appreciate. And I'll describe a little bit of why it's got that very long formal title. The original ONC, that we've now come to affectionately call ONC Classic, was founded in 2004 by executive order under then President Bush, and then put into statute in the High-Tech Act of 2009. We have two mission areas. One is to coordinate federal health IT strategy across the federal agencies. So not just within the federal, not just within the Department of Health and Human Services, but working with the VA, DoD, Social Security Administration, other organizations that have significant involvement in electronic health records and health information technology, and then working with the market to do everything we can to serve the public interest of having an open industry standard and open industry architecture for the exchange of information to best support the well-being, health and well-being of patients. So the two areas that that we've been very involved in is one that from the High-Tech Act of 2009, we were given the authority from the Congress to certify health information technologies. And we put together a program that certifies electronic health records that many of you may be familiar with and use, that now certifies the electronic health records that are used by 97% of hospitals and 86% of ambulatory providers across the country. So a very, very significant transformation of what was largely a paper-based healthcare delivery system to one that is, has most hospitals and ambulatory providers anyway using certified electronic health record products, turning us from a paper-based world, paper bricks and mortar world, to the opportunity for us to really think of ourselves as digital natives and to ask ourselves, if we are going to be digital natives, if we are starting with digital data first and foremost, how would we rethink the ways that we deliver healthcare, that we do medical science, that we do public health, that we do human services? All of those things, I think, are now here before us because of the large investments that we've made on the public and private side to be able to get us to this place of having this digital foundation. The 21st Century Cures Act of 2016, which was had very strong bipartisan support on the House and the Senate side, signed by President Obama in 2016, added a number of other elements to the ONC authorities, namely the information blocking rules, which prohibit the lack of sharing of information with other authorized parties. That includes patients as well as other providers, public health agencies, payers. Really, sort of covers the expanse of any other authorized party. The information blocking rules were put in place to make sure that everyone understands that now that we have these technologies, there is an expectation and an obligation to share that information with other authorized parties as applicable law allows. And then standards. It gave a specific direction to establish a minimum data set that I'll talk about in a second, that allows us to have better interoperability across the entire health ecosystem. And then also directed us to establish API-based exchange. So interoperability exchange using modern application programming interfaces or API standards that in healthcare are FHIR APIs, Fast Health Information Resources, Healthcare Information Resources. That is basically healthcare discovering the internet. And finally being able to have the kinds of more modern, convenient, granular, dynamic interoperability that I call, moving toward interactivity that, all of us experience in our day-to-day lives. When we use our, any app on your mobile device, for example, has a RESTful API in the background, making that very convenient, very easy to use, and giving a tremendous amount of functionality. That was the direction the 21st Century Cures Act, directing my office to establish that as a core construct for interoperability in healthcare. And then finally, TEFCA, which I'll talk about, the Trusted Exchange Framework and Common Agreement. Again, direction from the Congress to my office to establish a nationwide approach for network-to-network interoperability. And I'll describe that a little bit more. So let's dive in first to the reorganization. That was, sort of the original authorities establishing ONC, and we've built on that through a reorganization at the secretarial staff level to establish ASTP, the Assistant Secretary for Technology Policy. That was put in place in July of 2024, so not so long ago. But as you can imagine, there was a lot of build up to that, in terms of strategic thinking at the secretary's level of, what is it that we need to be able to do to recognize and to have better accountability and better ability to serve the American people as we think about the strategic uses of technology to to affect patients' lives. And it was a recognition that if you look across every mission area of the Department of Health and Human Services, and just as a reminder, the Department of Health and Human Services is the biggest domestic agency in the federal government, and it covers a tremendous sort of span and scope of activities, everything from National Institutes for Health and all of the work in research and discovery to the FDA, Food and Drug Administration, for safety and effectiveness of devices, biologics, drugs, food safety, it goes on and on and on. And then, healthcare delivery on the financing side and on the healthcare services side, healthcare services, delivery on the human services side and public health, just to really, in the CDC, a tremendous scope of activities here, but recognizing that if you look across the entire department, there isn't a mission area now that doesn't involve technology in some kind of strategic way. A lot of it owing to the fact that we invested, public and private, in those electronic health records that I talked about. So we have this digital foundation now of clinical data that now every single mission area is starting to say, how can we make data a core part of how we have better programmatic activities and better success accomplishing our missions on behalf of the American public. So it was that recognition that we're now at the point where we really need to have a department level approach to thinking about the strategic uses of technology separate from what the CIO's office does. And that was the establishment of the Assistant Secretary for Technology Policy. So as I said, it's really, establishing the HHS focus on technology innovation as a mission priority and an enabler, formalizing department level and cross-agency work so that we, have the ability to say, well, wait a minute, CDC is doing something in a key technology area over here, and it looks very similar to what the FDA is doing, and maybe we can get some synergies to be able to have a better use of taxpayer dollars and more effective programs if they're able to, sort of leverage common infrastructure and be able to have appropriate, as authorized by law, sharing of information, across those different programmatic activities. And it builds on well-established ONC coordination. So we've been in the market, so as I described before, certifying electronic health records, working with our federal agency partners. So it's kind of natural to say, well, if we're going to consolidate this kind of activity for technology generally, makes sense to build it on the chassis that ONC had already put in place as it related specifically to health information technology. So we've established a new Chief Technology Officer, the Office of the Chief Technology Office, which serves the department, and underneath that, Chief AI Officer, Chief Data Officer, and a new Digital Services Group. The Chief AI Officer is going to play a significant role, as the name implies, in AI. I'll get to AI a little bit later, but it's really a coordination function across the department to help us coordinate all of the AI activities that are going on across the department now, as is going on in almost every organization and every company across the country. So let me step back, talk a little bit about what are our focus areas as we think about data, interoperability, the mission objectives for health information technology, and I'll talk about data itself. I'll talk about TEFCA, which is primarily about interoperability, and then I'll talk about AI. And we'll do that very, very fast. And we kind of think of this in, as sort of a roadmap here, because you're thinking about, how do we keep building the digital foundation which is data standards. How do we make interoperability easier? I talked about TEFCA and APIs. How do we promote information sharing? I mean, one of the things that was reflected in those information blocking rules that I described before was the sort of the congressional sense that just because you build it doesn't mean they will come. Meaning that we spend $35 billion of taxpayer dollars for incentives to adopt electronic health records that were interoperable, but people weren't sharing in the ways that the Congress expected they would be sharing. So you need to have policies also that really, direct people to use those technologies to share information in the best interest of the patient. And then finally, how do we think about responsible use of the data once you've made it digital, once you've got it flowing? You need to think about, are there guardrails on the other side that we need to establish so that people aren't surprised or have the right expectations about, what's appropriate use of that information. So let me talk about data for a second. The U.S. Core Data for Interoperability, or US CDI, was a direction again from the 21st Century Cures Act. And what we do is every year we update this core minimum data set. And it's fast becoming the minimum data set of the healthcare delivery system. And why do I say that? Because it's required to be supported by those certified electronic health records that cover 97% of hospitals, 86% of physician offices across the country. And so it, is very much sort of serves that key role of saying, if I'm just going to get information out of any arbitrary electronic health record system, from a solo practice in Juneau, Alaska, let's say, to a hospital in Portland, Maine, to a federally qualified health center in Santa Fe, New Mexico, I should have an expectation that I can get the same basic minimum data aligned with basic open industry standards. And that ought to, that'll serve us well, right? And having scalability, that's the direction that, that we were given from the Congress, and that's now what's instantiated in those electronic health records. It's also something that's supported by private industry. So the Apple Health Record, for example, bases the technical specification for the Apple Health Record is based on the ONC standard for a FHIR API and the US CDI. It fully supports the US CDI. We don't regulate Apple. But why would Apple do that? Well, because they saw that as the only way that they could get scalability for their product across a very fragmented landscape. And that one of the only things that they could count on was that regulation that required that every electronic health record system that's used in hospitals and ambulatory provider settings has that minimum data set that they can then count on to incorporate and build their product on. So here, for those who haven't seen it, here is the US CDI in all of its glory. This is version 3 of the US CDI, which in the regulations that we call HTI 1, which were finalized just about a year ago. It was December 2023. This is the minimum data set that's required to be supported in the electronic health record systems that all of you use by 2026. Now, the US CDI version 1 is in your systems today. To the extent that you're using a certified electronic health record system. And the US CDI version 1, these are cumulative. So it's basically everything that you see there that doesn't have a star next to it is in the US CDI version 1 that's available in your system today. As you can see, it covers a wide variety of data elements that most of us, I think, would agree are a great initial snapshot. For following sort of the 80-20 rule of, if I just needed it for whatever clinical purpose, basic clinical purpose, a person visiting the emergency department, for example, this is a great starter set of data. And then obviously for specialty care, for specific kinds of acute care, you would want additional data elements on top of that for sure. But this serves that that need of a minimum data set. We also have a number of initiatives that we call US CDI Plus initiatives, which allow us to extend from that US CDI to support different activities that are that have particular unique needs that we can help support. So a number of our agency partners have been coming to us and asking for us to be able to provide extensions to the US CDI to be able to support their particular mission needs and their stakeholders who participate in those programs. So we have all the ones you see there on the left are active US CDI Plus engagements that we have with our federal agency partners. And we've got a public health US CDI Plus for public health that you're able to see, which is working with the CDC and jurisdictions across the country to create essentially like a nationwide public health data set, which we don't have in the market yet today. We're working with SAMHSA to launch a US CDI Plus for behavioral health. the various statuses and other kinds of information that are very important to the behavioral health segment of the market, working with SAMHSA to be able to establish those so that they can be available to behavioral health providers. With HRSA, for Federally Qualified Health Center reporting, which is now done via FHIR, end-to-end FHIR API exchange, where we worked with them to have the UDS reporting that many of you may be familiar with, that's a requirement on federally qualified health centers, is now enabled as tied to the US CDI and is available to be reported to HRSA via FHIR APIs. With CMS and the VA, we're working on US CDI Plus for quality to be able to support the quality roadmap that goes beyond the US CDI data elements. And then finally, cancer care. Working with the FDA, NIH, and the White House Cancer Moonshot team on a set of cancer data elements extended beyond the US CDI to support cancer research, diagnostics, therapeutics. And the first phase of that is already in place to support the CMMI, the Medicare, from CMS, the innovation projects from the CMMI, particularly the enhanced oncology model that is now starting to already report as of September of this year, using the first set of data elements that have come out of this US CDI Plus for Cancer initiative that some EHR vendors have voluntarily adopted to support their customers. So a lot of great activity, I would argue, on the data front. So let's talk about TEFCA. We got, better and better data, higher and higher quality data. Not perfect by any means, because there's a lot of variation in documentation practices, but we need to also focus on how do we share that information? How do we make it available to other organizations? The TEFCA Trusted Exchange Framework and Common Agreement went live on December 12th, 2023. So just actually, we're just on the anniversary, aren't we, of TEFCA's being live for 1 year. How do we think about network-to-network interoperability, and what does that mean? The analogy I like to use is, think about the way cell phone networks work today. You've got T-Mobile, Verizon, AT&T, and a number of other private sector networks that each of them is connected in the back end so that our user experience as a customer is as a single network. We purchase whatever phone we want, we use whatever provider we want, but we don't worry about whether an AT&T phone is going to connect with a Verizon phone. Those will absolutely connect because there's been a lot of hard work behind the scenes from a technical specification perspective, from a governance perspective, from a collaboration perspective, to make sure that we have that user experience. We have hundreds, literally hundreds of health information exchange networks across the country, some of them state local, many of them state local, regional health information exchanges, and some of them national or nationwide health information exchange networks, but they're not connected in the ways that we believe and that the Congress strongly believe they need to be. So that was the direction to my office, was establish a framework to connect those networks. So don't replace them by any means, actually supplement them and lift them up and help them have more market opportunity, more value for everyone by having them connected up with each other so that each of them doesn't have to figure out how to connect with the other one. They can have a nationwide approach to connecting with each other. So we've got 7 QHINs, as we call them, Qualified Health Information Networks, that are live. Those are the ones depicted in the left-hand column here. Many of you may be familiar with some of them, like Epic, for example, and then others you may be less familiar with. But the point is they cover the vast majority of electronic health record systems that are used by hospitals and provider organizations today, as well as health information exchange organizations, state and local ones that KANSA connects up. You've got a number of behavioral health and long-term post-acute care organizations, Point Click Care, the very large long-term and post-acute care vendor, just announced that they are going to be joining TEFCA through No2 there on the bottom. And then on the right-hand side, you have 3, what do we call, applicant QHINs or candidate QHINs who are just about to be designated to go live. They're just in the last testing phases, testing with all of the other QHINs. So at that point, we'll have 10 QHINs who voluntarily are stepping forward to connect with each other under a common agreement, so a common legal agreement, so you don't have to worry about sort of signing different legal agreements for this kind of exchange, that allows scalability across the industry using a common legal framework and common open industry technical standards. So we also have put in place a number of policies to help support trust. at the end of the day, these networks are about trust and they're about operationalizing trust. We've had issues in nationwide networks as well as some state and local networks related to the erosion of trust, where information has been shared in ways that the data holding entities didn't expect and had concerns about. And so we've worked very hard to say we need to establish TEFCA as a public-private approach that allows us to have a public participation that helps to lift up and get the private sector to the next level of interoperability that all of us want to be able to have. And as I pointed out, 10 networks have stepped forward voluntarily because the Congress did not give my office the authority to require anyone to participate in TEFCA, nor did it give us any funding to support organizations that are going to participate in TEFCA. So it's very much a public-private collaboration where we have to work very hard to say, how do we work together to establish something that together helps the market itself, move forward, and through their voluntary investments that all of them are making in this. So we've worked really hard to establish more and more policies to instantiate this idea of operationalized trust. So it now supports FHIR-based exchange. In April 2024, we put that policy into place, and then in July and August, we put into place a number of other policy, sort of innovations and breakthroughs that haven't really existed at scale in, across the country. So things like being able to have not just exchange for treatment, but for healthcare operations, for public health, for individual access, for example. All of those are exchange purposes that are supported in TEFCA, and all of them are, now on the path to being fully supported in the TEFCA model. Where are we? We're, got a number of different activities to be able to fill in some of the gaps, like getting payer-provider interoperability. Public health, as I'll describe in a second, has been a tremendous leap forward, actually. One of the great success stories, I would argue. And then things like delegates, which is how do we have intermediaries who are authorized? They're business associates. They perform valuable functions on behalf of covered entities, whether it's a payer or a provider. How do we have a set of policies that allows them to participate on behalf of the covered entities for whom they provide a tremendous amount of value-added services? Those policies are going into effect now in December as well to make this a very rich ecosystem that best serves the needs of organizations that are supporting patients. So we've had a lot of uptake. As you can see, this data is actually already dated because it was just through the half year, but over 400 hospitals already participating. I'm sure that number is much higher now. Epic, for example, has announced that their goal of having all of their customers on TEFCA before the end of this calendar year, which is just 18 days away, 19 days away. So tremendous amount of progress there. But over 100,000 individual clinicians now live on TEFCA, or live as of the end of June. So I'm sure it's many, many more now. So it's just a drop in the bucket in terms of the need, but it's only been live for 12 months, and we're very grateful for all hard work of our stakeholders in helping us move this forward. So let me just quickly describe public health, and then I'll just touch on AI and the activities we're doing there. There are now more than 50 public health jurisdictions across the country who are participating in TEFCA to be able to serve the public health needs of their local jurisdictions, which has been a tremendous leap forward, and really speaks to sort of the forward vision of these public health jurisdictions, recognizing as they did from the pandemic that we have to do things differently. And so they're stepping forward to say we need to be able to have this secure network interoperability to be able to allow us to exchange information with each other, for states that are adjoining, and you want to be able to share as much as possible with them, and to be able to get that information in much more efficient and effective ways from hospitals, from provider organizations than exists today. In terms of AI, let me just describe a couple of things. We, from a federal government perspective, there's sort of a number of different regulatory approaches as it relates to AI. I like to break it out into the healthcare products side and the healthcare uses side. So if you look at the middle column there, FDA has longstanding regulations related to devices, many of which are AI-enabled devices, whether it's software as a medical device, software in a medical device. The FDA has now approved over 1,000 of those devices for availability in the market, and that will continue. We know that there's more and more applicants who are in that category, and FDA is gearing itself up to be able to support the clearance process to make sure that those are safe and effective in the use in the market. And then my agency, ONC, or ASTP, that same rule that I described before that went into effect in December of last year, requires that certified electronic health record vendors, which again cover the vast majority of hospitals and ambulatory practices, are required to have a transparency to their users about the AI-enabled products that are in their electronic health records. So starting on January 1st, 2025, those EHR vendors are required to provide essentially a nutrition label for those of you who are users of those electronic health record products. And that, is Epic, Oracle Health, Athena Health, eClinicalWorks, there are, hundreds of electronic health records that are certified for use in the market. They are all, as of January 1st of 2025, so just 19 or 20 days away, are required to make available a dashboard, as it were, or a nutrition label, as it were, of the AI-enabled technologies that are in their products, so that it gives you the information that you would need to be able to decide whether this AI-enabled technology is appropriate for use in my setting. Now, we know there's a tremendous amount of work to do for education to say, well, that's great that I have information. How do I know whether that means it's a good product or a bad product? And we know that there's a lot more for us to do there, but we thought that the very first step that's important for everyone is just transparency, is to just say, make sure that, let's help the market work better, and let's have, sort of a race to the top rather than a race to the bottom, which would happen if you're not transparent about the sources of information that you're using in your product, about whether there's any external validation of your product, and whether you have any plans to maintain the product once it's been in the field. So that's coming in their electronic health records starting on January 1st. Last thing I'll just say is that we are also at work on a strategic plan, which we expect to finalize within the next month. That'll be made available. That covers AI uses across the entire Department of Health and Human Services, everything from medical product research and discovery all the way there on the left-hand side, through human services and public health on the right-hand side, looking at what are the market trends, what are the things that the federal government really should care about on behalf of the American public in terms of opportunities for using AI to benefit patients, and what are the cautions or the guardrails on the other side of it as we think about safety, as we think about health equity? What are the guardrails that we need to think about as well to allow that innovation to happen, in as expedient a manner as possible? Because on net, we believe that this set of technologies are going to be hugely beneficial for patients, and we want to be able to do what we can to make sure that people are excited about them, that they feel that they are benefiting them, and a part of that is making sure that they feel that they're safe as well. So thank you again for the opportunity to be here today, and I hope you enjoy the rest of the conference.
Dr. Tripathi, thank you so much for your time. We so appreciate it. And we will see you sometime in the new year.
Great. Thank you.
Thank you again.